morning. We'll get started. So this is Cornea free paper session 3, and it'll immediately follow by the finals. So what happens here is that all the presentations in this session, one of them will be automatically going to the finals, and that person does not have to present again because we're the same judges. Whereas the free paper 1 and 2, the winners, will be presenting again. That will be the finals. So we'll have whatever number of presentations for free paper 3, followed by 2 more papers, which will be from 1 and 2, who have won the top marks in those 2 sessions. So just for the benefit of judges, all of us will be judging you, the paper rather, not you. The duration of your paper is 5 minutes. Very, very important to finish on time. That's number 1. And if towards the last you're reaching you know how many slides you have, and you can see the timer there. And if you're reaching towards the end, please go to your last and just finish up your presentation within time. That's very important. And if the presenting author is not there or something like that, that's fine, but that person, we can't can't be for the competition. And of course, you have to be a ratified member to be for the competition. For the judges' benefit, after each presenter finishes, we are going to ask them questions. That is 1 minute time is permitted for that. And also no audience questions are permitted in the free paper session because that takes away the time from the session. And also if the audience asks tough questions, then that might bias us. So the questions are to be asked only by us. So we'll start off with Cornea 3, and the first presenter is Dr. Vijay Pai. Are you with Dr. Vijay Pai? You're the presenting author? Okay. You're Dr. Okay, Dr. Gokul is the presenting author. Cell components in differentiating amniotic membrane cells into limbal epithelial cells. So the timer should be set for 5 minutes. Yeah, and only when the presenter is ready, then you start the timer. Ready? Okay. Yeah. Please go ahead.
A very good morning to one and all. I'll be presenting on the role of cell components in the differentiation of amniotic membrane epithelial cells to limbal epithelial cells. Limbal stem cell deficiency, as we know, is one of the most common causes of corneal blindness in the world. Surgical methods for the treatment of LSCD have their own limitations and long-term complications. Stem cell therapies give a new hope in this regard. Our study was based on the idea that differentiation of human amniotic epithelial cells into limbal stem cells can be safe and a good option, as it is non-tumorigenic, less immunogenic, and can be applied in bilateral cases. The aim and objectives of our study were to determine the efficacy of isolated human limbal cell functional proteins treated onto amniotic membrane epithelial cells to transdifferentiate in vitro into limbal epithelial cells, and also to demonstrate the ex vivo growth and characterization of allogenic limbal epithelial cells. The study was done in our stem cell research and regenerative medicine lab. The limbal tissue from eyeball of deceased donor and amniotic membrane tissue from placenta following an elective LSCS of a healthier donor were used in our study. The above tissues, which were tested positive for serology, were excluded from our study. As for amniotic membrane cell culture medium, we used Dalbecko's modified Eagle medium, low glucose, 10% fetal bovine serum, and also 1% antibiotic antimycotic solution. For limbal stem cells culture medium, we used the above same DMEM medium, coupled with a few growth factors such as insulin, transferrin, selenium, epidermal growth factor, and hydrocortisone. As for exosome isolation, we use polyethylene glycol, 6,000 molecular weight, 50% weight by volume, the Dalbecko's phosphate buffer solution, and buffer solution such as HEPS. We did protein estimation by bisynchronic acid method and also used Western blot protein markers. As for immunocytochemistry and antibodies against ABCG2, cytokeratin 12, E-cadherin, vimentin, and GAPDH markers were used. Firstly, we isolated the amniotic membrane epithelial cells. The amniotic membrane was stripped off from the chorion and was subjected to PBS wash to clear out the debris and blood clots, following which enzymatic digestion of the amniotic membrane was done with 0.5% EDTA trypsin solution, following which primary culture of amniotic membrane cells was done onto the culture medium, which is a DMEM medium. Subculturing of amniotic membrane cells were carried out into multiple cell passages until the cells attained a confluency of 60 to 70%. Similarly, we isolated the limbal epithelial cells. A 2 into 2 mm biopsy tissue was taken from the corneoscleral corneoscleral rim and was cut into multiple subsections, which was transferred onto the primary culture medium. Once the sufficient cell passages were attained with significant confluency, the PEG precipitation of the limbal exosomes were carried out from limbal stem cell medium, and exosomes obtained were tested for purity and protein quantification using nanoparticle tracking analysis and scanning electron microscopy. Post 70 to 80% confluency, the third passage of AME cells were treated with limbal stem cell exosomes at a concentration of 10 microgram per ml concentration. After 48 hours in CO2 incubator at 37 degrees Celsius, the differentiated stem cells were observed for morphology and subjected to Western blotting and immunocytochemistry. Coming to results, we observed the morphology of AME cells at the end of third cell passage and was observed to be spindle-shaped cells. As we can see in the marker is not there. Coming to limbal epithelial cells, similarly we observed cuboidal epithelial cells at the end of third cell passages. Nanoparticle tracking analysis was done to quantify the particle size and was noted to be 150 to 200 nanometer peak concentration and was correlated using scanning electron microscopy. The morphology of tuned AME cells at the end of 60 hours was significantly different from that of the control group, that is the AME cells in the control group, and at the end of 5 days we noted that there will be significant doubling time was noted. Western blotting analysis was done to quantify the protein expression markers, and there was significant expression in ABCG2, E-cadherin, vimentin, and keratin 12. Similarly, on immunocytochemistry, the above limbal epithelial cell markers were significantly expressed. The limbal epithelial-like cells transdifferentiated from tuned amniotic membrane cells are morphologically different from the amniotic membrane cells and has lesser doubling time than the latter. Relative expression of limbal stem cell markers are more in the transdifferentiated cells when compared to AME cells. The amniotic membrane epithelial cells are capable of transdifferentiating into progenitor cells, thereby suggesting an alternative source of stem cells. Also, the exosomes derived from cells of limbal epithelium are efficient in the tuning of amniotic membrane cells. Also, I'd like to conclude by saying that donor eyeballs can also be used as a safe source for the necessary exosomes, and their availability can be put to prompt used. We hope that our study actually opens a new door for further research in this aspect regarding the tuned AME cells and its practical implementation in treating LSCD. Thank you.
Very nice presentation. I just wanted to know what are the markers which you used for the limbal epithelial cells as well as for the amniotic membrane epithelial cells?
So we use the markers ABCG2, vimentin, E-cadherin, and cytokeratin 12.
Okay.
Also, as for limbal exosomes, the markers are sent. We study for CD9, CD81, and CD63, and a negative marker, but the results are pending for that. We have not.
Okay. So the phenotype which you showed was not looking like a corneal epithelial phenotype on your amniotic membrane epithelial cell. They were still spindle shaped. So was there any change in the phenotype, or phenotype remained spindle shape only?
So you mean the tuned amniotic after we use the exosomes?
Yes.
So we cannot certain that they are limbal epithelial cells. They are one thing we certified was that the amniotic membrane cells are capable of transdifferentiating into a progenitor cells. In this aspect, the cells obtained were definitely not spindle shaped, but also we can see at the end of 5 days that cells have become more flattened, more inclining towards a cuboidal shape. So we can only say these are limbal-like cells.
Limbal-like cells.
Not limbal.
Yeah, sure. But very nice presentation.
Thank you, sir.
Thank you.
Is Dr. Rinki here? Dr. Rinki Agarwal?
This was Vijay.
Is Dr. Sonam here? So we'll go to the third in the series presentation, anterior segment OCT in congenital corneal opacity, being presented by Dr. Sonam Yangzes.
Yes. Very good morning, everyone. I'm going to present anterior segment OCT in congenital corneal opacities. So congenital corneal opacities are basically very heterogeneically heterogeneous group of disorders, and early diagnosis is essential in such cases because of deep vision deprivation amblyopia, and measurement of the corneal thickness plays an important role in both diagnostic therapeutic assessments, because majority of these kids have glaucoma as well, and various tools are available with us. And ultrasound pachymetry is a standard in measuring the corneal thickness, but it's a contact procedure and perpendicularity of the probe is essential. And Swepsos OCT is nowadays more frequently used in babies as well, and it's a non-invasive, non-contact, and a fast method. There are various studies which had compared AIOCMT with that of ultrasound biomicroscopy for assessment of the anterior segment, and they have found that the earliest study published back in 2007 found that in clear corneas, they are quite comparable. But in corneal opacity, there are studies which show that there's a variable correlation or interchangeability between these two modalities. This is a recently published article from our department itself, where we found that the AIOCMT does provide preliminary data, and it can help us in diagnosing at an early stage, but UVM remains the gold standard. So our objective was to determine the interchangeability of the pachymetry measures by AIOCMT with that of the UVM. So it was a comparative consecutive case series of children which were enrolled over a period of 2 years and less than 5 years of age. And mainly we discussed the pachymetry, we studied the pachymetry. Just a small video to show how we measured the swept source, or how we did the swept source OCT in children after proparacaine instillation. Flying baby technique was used to stabilize the head and the neck of the patient. And then because it does not require any fixation, incidental fixation is fine, so we got the images. So in order to measure the pachymetry measurements, we took the scleral spur to scleral spur distance, and the central corneal thickness was measured. AIOCMT has this technology inbuilt, but for UVM, we overlap the images between the UVM and the OCT to get the central area, like in this image. But the cases which had severe anterior segment dysgenesis, where the sulcus anatomy was distorted, both the images were overlapped together, and the centralmost area was assessed for measuring the CCT. So 54 eyes of 36 patients were imaged using both UVM and AIOCMT, and females were more common, and the age group varied from 11 days to 5 years. So we found that the mean pachymetry of UVM was higher compared to that of the AIOCMT, which was slightly different from the previous studies, maybe because the previous studies were done in adults without any anterior segment dysgenesis. So here, this image also shows the same thing. And the difference in the pachymetry between UVM and AIOCMT was statistically significant. Then here on this scatter plot, we can see there are multiple outliers because of the variable corneal thicknesses, and blind Allman plot showed that there was no interchangeability between these two imaging modalities. Just a few examples, like here we can see that this is a case of type 1 Peters anomaly, where UVM has shown 680 microns as the thickness, while AIOCMT is showing 651. But if you go slightly, maybe like 2 millimeters away from the center cornea, then the thickness is 410 microns. So just slight change in the central corneal causes a huge variation in the CCT. While in this case here you can see there's a thick retrocorneal membrane, where in the UVM there is no delineation between the cornea as well as the membrane because of the poor resolution, you can see, because it appears uniformly hyperechoic, while on the AIOCMT the retrocorneal membrane is very beautifully delineated, which can help us in measuring the corneal thickness better. Of course, the study had limitations because of lack of centration while doing UVM as well as OCT. Manual measurement was done for UVM, so observant bias is present, and those tissues, corneas which had stromal excavation, side-to-side variability was high. Even though the sample size is high, but it's one of the largest studies so far with the maximum number of patients with congenital corneal opacity. But there was a lack of control group of children, age match controls. So I would like to conclude by saying that AIOCMT and UVM correlate well in majority of the cases, but pachymetry values are not interchangeable. Retrocorneal membranes were better delineated on AIOCMT owing to a better resolution, so we may rely on it better for a corneal thickness measurement. And the eyes with posterior corneal excavation, like in Peters anomaly, may affect the accurate pachymetry measurements. UVM still is the modality of choice as it penetrates better in cases, especially in cases with retrocorneal membranes and dense lenticular adhesions. Thank you.
Excellent, very good presentation, Sona. Sona, my question is that you said that you included consecutive cases. So there were no cases that you needed to exclude, or?
Ma'am, all those children who who were diagnosed with bilateral or unilateral congenital corneal opacities, and those who did not have, yes, we did exclude patients who had retinal detachment, associated retinal anomalies like FEVR, ROPs, stage 5, 4, 5 ROPs, ma'am. Other than that, those who had only anterior segment involvement, all the children were included. We did exclude children who had history of nutritional causes like vitamin A deficiency, infectious causes, After ruling those out, ma'am, then other cases were included.
So those, why did you
Traumatic
exclude
also.
those cases?
Because, ma'am, the external factors, the acquired factors will affect their morphology of the cases, and we wanted to focus on children with specifically on corneal opacities which are present congenitally or since birth, ma'am. We didn't want to have any bias based on the acquired cause like scarring and all will lead to excessively thin corneas in such children, and we wanted to look at the cases which were totally naive otherwise.
So based on your study, which is the one indication where you think OCT wins over UBM?
Ma'am, now we are routinely doing OCTs in every single child, and we have now realized, ma'am, that just on unpublished data that up to 30 to 35% of the cases, ma'am, the children sometimes never get fit for a UBM for a pediatric examination and anesthesia. And even in those children, ma'am, we were able to make the diagnosis. At the same time, we could refer the patient with more information to the geneticist. And we are able to diagnose various anomalies as well as systemic as well as like syndromic associations because of our OCT, ma'am. So it does provide us a lot of information. Now it has been included as a part of the routine protocol for all children, ma'am. Thank you, ma'am.
Next is, so Dr. Mrinalani is there?
So Dr. Rinki Agarwal.
Okay. Dr. Rinki?
So Dr. Rinki Agarwal is here. Please.
Okay. So she is going to present her paper on pneumatic iridodialysis repair.
Good morning, everybody. I'm going to present my case series on pneumatic iridodialysis repair. So iridodialysis may occur secondary to ocular trauma, or inadvertently during intraocular surgery, and it is reported to occur 0.2% after cataract surgery. If the tears are small, we may actually leave them as such, but if they are large, they may cause glare photophobia, and so they require reapproximation. Various suture-assisted techniques have been described, but they are technically demanding and they require surgical expertise and they can cause certain problems. So 20% sulfur hexafluoride or SF6 is an inert isoexpansile gas that is commonly used as a retinal tampering agent as well as for desmetopexy. It is said to absorb over 2 weeks, and it has been described for iridodialysis repair, but there is little peer-reviewed literature. So we describe the results of this minimally invasive iridodialysis repair in 4 cases. So what we did was a well-informed and free will consent was taken from patient. Intraoperatively, whatever complications happened, patients were informed that we are going to do this. So for those where patients were taken for second sitting, we had done cleaning and draping and aseptic precautions. Side port was made opposite to the side of iridodialysis. Entire AC was filled with 20% SF6 till the iris was convex down, and this tamponade was maintained for 5 minutes. AC was decompressed after that to fill 2/3 of its volume, and side port was then hydrated. Appropriate posture was maintained for first 24 hours. Topical antibiotic steroid combination with cycloplegic homatropin was given for 1 month. So first case was of a 77-year-old female patient who was referred to a center for iridodialysis repair on 3rd day after SICS. The patient was pseudophakic with a well-placed PCLin bag. The primary surgeon noted a 4-block-hour large supranasal iridodialysis during crystalline lens delivery from superior scleral wound. So we injected this SF6 20%, and then we advised her head and elevation for 1 week. On next day follow-up, the iris was found to be attached to the root. So this was the case that was sent. This is a preoperative photograph, and this is the intraoperative photograph where we injected SF6, and we can see that pupil is more or less round. This is day 1 postoperative photograph. We can see SF6 is forming a big bubble, and the pupil is also appeared to have gone back. This is at 1 month follow-up. We can see that almost near normal pupillary iris configuration is maintained. This is the patient's gonioscopy that we have done. We have done that iris was round, but there was a small gaping of this at iris root, but this did not cause any problem to the patient. It was only visible on gonioscopy. In case 2, it was a 65-year-old female patient who suffered an inadvertent 270 degrees iridodialysis while crystal lens delivery during SICS. So after placing PCL in bag, the iris was gently reposited with an iris repositor, and the same technique was followed. The patient was advised foot end elevation for next 1 week. There was an approximation of iris to its root from either side of the tear with a residual tear from 4 o'clock to 10 o'clock. This fell in the aphakic area, so no second surgery was taken for iridodialysis repair. So I'm sorry I don't have its intraoperative photographs, but this was how the tear was there. It was deposited back, and this is how after 1 month we can see that it is just reduced to a smaller inferior one quadrant area which is falling in this aphakic area. So the patient was not symptomatic, so second sitting was not taken. In case 3, it was an 18-year-old male who presented with 180-degree supranasal iridodialysis from 10 o'clock to 3 o'clock after blunt trauma with a cricket ball. The patient was a phakic with clear lens. So for this patient, 20% SF6 was injected intracamerally under peribulbar anesthesia, but the iris did not get deposited, and so immediately a suture-assisted repair was taken. In this suture-assisted repair, we found that there was an intraoperative lens touch with suture needle, but at 1 month follow-up, it was not significant. So the patient had 6/6 vision. So this was the case. We can see such a big iridodialysis was there. We tried to reposit it with SF6 20%, but it could not be reposited. So immediate suture-assisted repair was undertaken. At 1 month follow-up, we can see a round pupil, completely clear AC, and there was a small cataract, but it was not visually significant. So we did nothing. In case 4, again this was a 68-year-old male patient experienced 4 clock hours inferonasal iridodialysis while undergoing SICS during lens delivery. Again 20% SF6 was injected after depositing the iris back and placing IL in sulcus. Patient was advised foot end elevation. Only 1 clock hour of iris remained unattached at 1 month follow-up, as the patient did not have any symptoms, so second surgery was not undertaken. This was the case. You can see that there is such a big iridodialysis that is noted intraoperatively, and after SF6 injection, this is on day 1 poster, we can see the iris is reposited well. So results are that in 3 out of 4 patients who had iris tear during lens delivery during SICS, we had successful reapposition of iris to its roots. Even though it was not complete, it led to an asymptomatic phase in the patient, so second surgery was not required. So there was no incidence of eccentric pupil. Gonioscopy also showed a well-attached iris. Maybe some gaping was noted in these cases. So other than that, there was no much of AC reaction, no rise of intraocular pressure, or no redetachment of iris noted. So this is the case detail that are summarized. So the positioning posture of the patient was importantly maintained according to the presence of the iridodialysis area. So in these cases where the head end elevation was given, where there was inferior iridodialysis, superior iridodialysis, and where there was inferior, then foot end elevation was given. So we believe that this entire technique depends on the presumption that iris will follow its natural anatomical course to get reapproximated to its root on injecting SF6 from above. Unlike a tractional pull which is happening from a suture, here it is following its natural course. So with SF6 providing further tamponade for next 2 weeks, adhesions are expected to form between iris and its root, and thus leading to a permanent refixation of iris without the need for any sutures. So we can see this. So it is important that we had certain limitations also, like there can be expansion of SF6, but here we do not have any. But because we reduce the AC volume to 2/3 of the SF6 filling. So its failure in this young male with post-traumatic iridodialysis suggests that thick elastic iris and anterior curvature of crystalline lens prevent spontaneous reattachment. So making them unsuitable for SF6 repair. In young patients, it may not be very successful. So we can tell that we had 75% success rate in our patients. It is helpful in elderly pseudophakic patients with thin atrophic iris, especially with iatrogenic tears accompanying cataract surgery, especially in novice surgeons where they may not be possible to, they are already in panicky state, they can only inject SF6 and leave it like that. So we believe this technique carries potential of outpatient iridodialysis repair procedure that can be even attempted on slit lamp, but requires further studies. Thank you.
Yeah, nice case, but...
There's no audience question
Yeah.
here. No audience question. It's free paper session. I'm sorry, there's no audience question. Sir, it's a free paper session. I'm sorry, there's no audience question, which was earlier told by the chairperson.
So, though it's a limited case series, like in third case, you have to resort to suturing.
Yes, sir.
But like in second case, where the dialysis was inferior one, even after, almost 270 clock hours, 270 degrees. So there was still a lot of gap, and it was inferior. So patient must be having a lot of maybe photophobic symptoms. So what do you advocate after going through these 4 cases? Is it really worth it, doing it and waiting and watching and then go on to do a suture repair? And one more in addition to that, on the table, did you put any meiotic or dilator agent? Though you do advocate homoatropine or cycloplegic post-operatively, but did you do any of the things like any meiotic or so that there could be unrolling, which may be difficult once the dialysis is too large?
Okay. So first, your question, whether it is worth it. Sir, from my experience, I have really found it worth it. Even though I have done it in 4 cases, in all those individuals, this is the case photograph that I am showing where the inferior dialysis was big enough, but the patient did not have photophobia, maybe because it was falling through the aphakic area. It was not in the phakic area, so the light entering the eye was less. The patient did not have much of glaucoma or anything, which was with 270 degrees hydrodialysis. If we take a big repair in the 70 years old individuals, then the chances of second surgery, the sutures and all that itself carries a lot of problems, and it requires a lot of surgical expertise. While this is a very simple one where we inject SF6 and leave it to take care, I may say even if you require second surgery, the amount of suturing required for second surgery will decrease dramatically even if the surgeon wants to undertake second surgery. Secondly, novice surgeons, especially those who are doing SICS, they are quite panicky in that state. So they do not know what to do. They can't suture it at that time. The wound is large. They cannot make the scleral pocket to make a bury those sutures, prolene sutures. So in that case, just depositing and leaving with SF6 will help them in some way at least. In the future, even if they require a second intervention, the chances will be less. In our cases, we did not require because the patients were elderly. They did not have much of complaints in the future. So we left it like that. But had some patient complain, then we would have even undertaken a suture-assisted repair in the second sitting, sir.
Okay.
And then
Thank you,
intraoperatively,
Rinki. We'll go to the next presentation. Just
Thank
once again, Rinki, and to everybody else, that once the timer is up, it's up. Because when you go over time like you did, it decreases your marks.
Okay.
So try to stick to time.
Okay.
The next is Dr. Mrinalini Singh here. Dr. Nikita Sharma. Dr. Rakshit Agarwal. Feeling depressed. Who is here? Sorry? Niharika. I was just coming to your name. Okay. I was getting depressed, so I said, let me ask. So we're going to Dr. Niharika Arya's presentation.
So good morning, everyone. Today I am presenting a study of corneal endothelium changes in the patients of diabetes mellitus and the angle closure glaucoma. Corneal endothelial cell is derived from the neural crest as a single layer of hexagonal cells whose function is to maintain the corneal clarity. Over 60% of the endothelial cells are hexagonal in shape. The size and shapes of the endothelial cells help best in maintaining the fluid barrier functions of the endothelium. Endothelial cell density in the normal healthy corneal cell decreases with the age, and once damaged, remaining cells enlarge to cover up the lost area known as the polymegathism. So oxidative and the osmotic stress from the excessive activation of the polyol pathway and the accumulation of sorbitol results in the corneal endothelial damage in diabetic patients. Anterior segment inflammation induces from the inflammatory cytokines in aqueous humor results with the endothelial cell damage in the glaucomatous patients. All the studies were comparative with the normal population, but this study has been designed to assess a possible effect of intraocular inflammation on corneal endothelium in eyes with angle closure glaucoma and diabetes mellitus. Since a majority of the patients are elderly, they often need surgery for cataract. Determining the corneal endothelial cell morphology in these patients before surgery would help in taking certain precautions during the surgery so as to cause least endothelial damage and result in better surgical outcome. So to study the corneal endothelial cell density and morphology in diabetes and the glaucoma patients, and objective is to assess a possible effect of intraocular inflammation on corneal endothelium and to analyze the corneal endothelial cell changes with diabetes. So all previously diagnosed disease were included in 2 groups, namely the diabetes and the angle closure with an average age of 45 to 80 years. The study was a cross-sectional hospital-based study, and the age group inclusion was the age group between the 45 and 80, and the patients were glaucoma patients and the diabetes patients. Exclusion criteria: subluxated cataract, traumatic cataract, combined procedures, patients having undergone any prior keratorefractive procedures. So the methods of investigations include the best-corrected visual acuity, detailed slit lamp examination, IOP measurements, gonioscopy, dilated examination, and the specular microscopy. So the result came, the study confirmed that there is a significant increase in the center corneal thickness of 47.9% in diabetes patients compared to the 31.3% in glaucoma. And the study also found a significant decrease in the endothelial cell density with a 16.7% in diabetes and 12.5% in glaucoma patients. There was a significant increase in the coefficient of variation, that is 64.6%, and decrease in hexagonality of 91.7% in diabetes patients as compared to angle closure glaucoma. So in our study, means the mean center corneal thickness was higher in diabetes, our study is consistent with the McNamara et al. Study. In our study, there is a mean endothelial cell density is lower in diabetes mellitus, which is conclusion is consistent with the Nagraj et al. Study that shows the decrease in the endothelial cell density and increase in the center corneal thickness in diabetic when it is compared to the non-diabetic group. In our study, we concluded that the mean coefficient of variation comparison distance is significantly higher in diabetes, which is consistent with the Cho MM et al. Studies. In our study, we also found that the mean hexagonality comparison according to the disease showing significant changes in diabetes mellitus, which the study in the same study was done by the Sudarshan et al. So our conclusion is, our study confirmed that there is a significant increase in center corneal thickness, decrease in endothelial cell density, increase in the coefficient of variation, and decrease in hexagonality. Age showed no significant effect on the corneal parameters in any disease group. So we thus recommend that it is important to take optimal preoperative and intraoperative measures to protect the corneal endothelium in all the diabetes mellitus and angle closure glaucoma patient during any subsequent intraocular surgeries. Thank you.
Thank you, Dr. Arya. Very nice presentation. So my questions are that you studied the corneal endothelial changes in patients with both diabetes mellitus and also having angle closure, or they were two separate groups?
They were two separate entities.
So in many of your results, why did you compare diabetes mellitus with angle closure? You should be comparing with normals. Diabetes with normals, angle closure with normals.
So, ma'am, already the studies were gone with the comparative with the normal populations. So in our OPD, there is mostly the patients came with the angle closures and the diabetes patients, and they need a cataract surgery.
So I just wanted clarity. So your purpose of the study is you have two groups of population.
Yes.
That is, one is diabetic patients.
Yes.
The second is angle closure patients.
Yes, ma'am.
So, and then you're looking at the endothelial changes.
Endothelial changes. So
but your purpose is not to compare between the two groups.
No, ma'am. It's
so
just
then
like
why in your results have you compared? You need not do that. That's what I'm trying to tell you.
Yes, ma'am.
You need not compare the two because that's not your purpose. So you're confusing.
No, ma'am, it's not a comparative. It's just like they in future they need a cataract surgery. So we can counsel them about the visual prognosis after the cataract surgery. That not because of any complication there can be possible.
We'll discuss this offline because I don't think you're getting my point.
So
okay.
Just one question.
Yes.
But don't you think even otherwise we should be using all the optimal measures to protect endothelium in all cases of cataract?
No, sir.
So we don't take it lightly.
Yes,
that was the concluding slide. So
yes,
we should be taking all the measures. That is just a comment. Yeah.
I totally agree with sir.
Yes, sir.
One question is that whenever you do any study, you want to establish causality. When you're trying to get two things correlating with each other, I wish when you next time look at your own study, look at the causality, how to establish causality of your finding, right? And you will find out that sometime can be chance findings and which you try to interpret in a way which suits you, but does it actually satisfy the criteria of causality? Okay.
I have a question. Did you use any control for your study?
No,
in
sir.
any way? Then how can you say that these changes are age-related normal or they are not normal? Because diabetes, and you cannot compare two things, diabetes and either you have mixed two studies together, you have taken two studies and you are presenting it, or
No, sir.
They are two separate entities.
Yes, sir.
Because age-related you should have compared with the age also, and you should
with
have
the
control
normal.
also.
So there are a lot of confounding factors. So normal attrition rate, how the attrition rate differs in diabetics, were the age groups different? Your age group is 45 to 80.
80 years.
So at 40 and 80, the attrition rate in 40 years around 0.4 to 0.6% every year. That will also vary. So there are a lot of confounding factors. So, but anyway, it's a good study.
Thank you. Thank you.
Thank you, Dr. Arya. So who is next? Again, I'm not going to ask if so-and-so is present. Any other presenters available here?
I don't think so.
So we have quite a few remaining. Dr. Ashmita Adhikari, is she here? Dr. Chandra Devi? Dr. Kekashan Siddiqui? Sorry, Dr. Smita Harne. That should have been the last paper was Dr. Smita Harne. No.
No.
Anybody from the session is remaining here to present from Cornea 3? No. So we'll take that as no. We have two more papers to be presented. That is...
Only 4 are present.
Doctor? Yeah, so we have 2 papers to be presented from, these are the best of Cornea 1 and Cornea 2. Is Dr. Vinisha present here? Yeah. And Dr. Garima present here? All right. So the first paper I have in my list is from Dr. Vinisha. So for the judges, please note that these 2 papers that are coming up now, they're the best of Cornea 1 and Cornea 2. So you can just score them as per your scoring, and the scientific committee will pick up all our scores, and they will be declaring the winners. So we won't declare the winners at the end of the session. So Dr. Vinisha is presenting a case series showing clinico-etiological profile and management of PUK.
A very good morning, respected judges. My name is Dr. Vinisha Fonseca. I'm a second year PG student from Sarojini Devi Eye Hospital, Hyderabad. My paper is on a case series showing the clinico-etiological profile and management of peripheral ulcerative keratitis under the guidance of Dr. Vijayalakshmi ma'am. So PUK is an inflammatory disease. It starts off as a subepithelial infiltrate with an overlying epithelial defect and progressive corneal thinning. It can have systemic or local causes, and Murren's ulcer is a diagnosis of exclusion without associated scleritis or collagen vascular diseases. It affects the peripheral cornea. Here you have collagenases and matrix metalloproteinases, which cause progressive stromal lysis. My aim is to study the demographic profile, clinical features, etiology, management, and outcome in patients with PUK. So coming to methods, it's a prospective interventional case series conducted over a period of 6 months with a follow-up of 6 months. A total of 22 eyes of 12 patients were included in the study. A thorough clinical history and physical examination was done. We included all cases of a crescent-shaped ulcer, 2 mm within the limbus, and excluded any PUK-like lesions like neurotrophic ulcer or marginal keratitis. Methodology, the best corrected visual acuity was recorded on Snellens. A slit-lamp examination was done. Fluorescein staining to see the extent of the epithelial defect, and IOP as if we're going to start steroids in these patients. A battery of lab investigations like RA factor, ANA, ANCA, Manto, chest X-ray, HIV, and corneal scraping was done to rule out to come to an etiology. Coming to management, it could be medically or surgically based on severity. Steroids are the mainstay of treatment as they reduce inflammation. We follow a step ladder pattern wherein we start with topical steroids. If needed, we can use systemic oral or injectables. Adjuvants like cycloplegics, anti-glaucoma, tears, supplements, and antimicrobials are also needed to be added. In cases not responding to steroids, could be started on immunomodulatory agents. Surgery is indicated in cases of impending perforation to maintain tectonic stability, failure of medical therapy, and for visual rehabilitation. Conjunctival resection can be done 2 clock hours on either side of the ulcer. In small perforations, we can do cyanacrylate glue with a bandage contact lens. And for larger perforations, we would require a patch graft sutured with 10-0 nylon. Penetrating keratoplasty is our last resort. So coming to my results, at 22 eyes of 12 patients, out of this, most were males. Mean age was 70 years. Most were from rural areas. We had a bilateral involvement seen in most cases. Most presented with vision of counting fingers at 1 meter, around 7 people. They came with pain, photophobia, vomit, watering, and most of them presented 1 month after the start of symptoms. The inferonasal quadrant was mostly involved, as tear pooling tends to occur most commonly here. Based on stromal involvement, we divided into mild, moderate, and severe. Associated ocular findings like mebomitis, corneal edema, dysmetocele or corneal thinning, finally perforation with iris plugging, and scleritis was seen in some cases. After investigating for a cause, we came to a conclusion that in most cases there was no etiology, and hence we say that Murren's is the most common etiology. RA factor was positive in 3 cases and ANA in 2 cases. Scraping was negative for all of our cases. The primary goals in management are to decrease inflammation, promote epithelial healing, to prevent perforation and restore vision. Topical steroids were used in 14 cases and 5 thinned out cases after applying glue BCL, and IV methylprednisolone were added in 3 cases prior to a corneal patch graft. The rheumatologist started 3 patients on immunomodulatory agents like methotrexate, those having a systemic disease. Coming to surgeries, in 5 cases we did glue BCL, in 7 cases a conjunctival resection along with BCL, and patch graft was done in 3 cases. This is a surgical video demonstrating the resection. Around 3 mm is cut. Here we decrease the collagenases and the inflammatory cells coming via the blood vessels, and also we apply glue. This also has an anti-inflammatory effect. This is the comparative post-op results. Although the vision improved, 3 eyes had a recurrence. My limitations were a small sample size and inadequate duration of follow-up. A similar study was conducted by Sharma et al. In North India. There they had a larger sample size, but unilateral presentation was more common. In conclusion, thorough ocular and systemic investigations are needed to detect the etiology. Delayed presentation resulted in a more severe disease, hence necessitating awareness. PUK may be the initial presentation of potentially life-threatening disease. And treatment should be tailored. In mild cases, medically it can be treated, but most severe cases may require surgery to preserve the globe integrity. We have to follow up these patients almost lifelong to see for recurrence, infection, and graft rejection. And we have to partner with a rheumatologist, as these diseases with having a systemic component have high morbidity. These are my references. Thank you.
You said you divide into mild, moderate, and severe.
Yes.
So, was there any reference for this, or any protocol you used for this?
So basically, we started on topical steroids for the mild cases, but when there was severe
No,
thinning.
this division of mild, moderate, and severe. Was there any reference for this?
So.
Or you divided by yourself?
So by ourselves, sir, based on, and we refer
based
to
on the clinical findings, you said.
Yes, sir. Like 50% of the stroma involvement or 2 clock hours, that would be mild. 2 to 4 clock hours, more than 50% would be moderate. Impending perforation or already perforated would be severe.
Fine, but I'll suggest in future if you use any kind of this kind of classification, you should have a reference.
Okay. Sir, actually in the similar study done by Sharma ma'am, this she had
Oh, she had used it, so you
yes.
should have taken that reference.
Yes, sir, okay.
All right, thank you, Dr. Venetia. We go to the second presentation in this part of the program today, Dr. Garima. So the final presenter for this morning is Dr. Garima, who's going to be presenting factors influencing corneal haze post-collagen cross-linking in keratoconus treatment.
Good morning, everyone. Today, I'll be presenting my paper on factors influencing corneal haze post-collagen cross-linking in keratoconus treatment. This is my financial disclosure. So, as we all know, keratoconus is a progressive condition which presents with corneal protrusion and thinning, which results in irregular myopic astigmatism. It is usually bilateral but asymmetric, presenting mostly at around second to third decade. For mild to moderate cases, we often opt for corneal collagen cross-linking using riboflavin and UVA light. The most common complication post this procedure is corneal haze formation, which leads to increased backward scattering of light, increased corneal densitometry values, and that results in temporary suboptimal visual acuity. So about corneal haze post cross-linking, it can be assessed qualitatively using slit lamp biomicroscope, confocal microscopy, as well as anterior segment ASO setting. Quantitatively, it can be checked using shine plug photography. In many studies, they have checked using in vivo confocal microscopy that reveal that there is increased density of the extracellular fibrillar matrix, as well as reduced density of anterior keratocytes, which becomes hyper-reflective in the treated zone. Using pentacam, we have also analyzed the corneal densitometry that automatically locates the corneal apex, which analyze an area around the diameter of 12 mm, and it further subdivides it into 4 zones, which are central 2 mm, 2 to 6 mm, 6 to 10 mm, and 10 to 12 mm respectively. The outward output is being measured in terms of grayscale units, which tells the minimum light scatter and label it as 0, which indicates maximum transparency, and maximum light scatter, which is labeled as 100, which indicates minimum transparency. So the objectives were, the primary objective was to determine the factors influencing corneal haze formation following collagen cross-linking procedure, and to address the association of pachymetry, keratometry, and their changes with corneal haze formation. The secondary objective was to analyze the relationship between corneal haze and visual outcome. So it was a prospective observational study done for 12 months on 84 keratogonic eyes. The preoperative assessment was done by measuring uncorrected and best corrected visual acuity, slit lamp examination, and then pentacam was done to measure the K1, K2, Kmax, K-mean reading, central corneal thickness, thinnest point, densitometry values, ART max, and progression index was noted. Post cross-linking procedures, again visual acuity was measured, and then slit lamp biomicroscopy examination was done to measure the corneal haze, and grading was done. Subsequently, follow-up visit was done on 1st, 3rd, 6th, and 12th month, and all the factors were reassessed and documented respectively. The result was that in our study, the mean age of presentation was 19 years and 8 months, and majority of them belonged to 16 to 20 years, followed by 21 to 25 years of age group. In our study, there were 48 females and 36 males. The mean baseline uncorrected visual acuity showed an improvement by one Snellen line at 1 month, which plateaued in 3 months. Subsequently, it improved by one Snellen line at 6 months, again which plateaued at 1 year. The mean baseline BCVA, which remained unchanged, but however, it improved by 1 line at the end of 3 months, and then it remained plateaued. Both the K-mean and the K-max reading peaked at 1 month post-CXCL with subsequent dip. The thinnest corneal thickness largely reduced until first 3 months, yet showing an increasing trend from the 6 months onwards. Based on the slit lamp grading of corneal haze, at 1 month, nearly almost 98% of our patients had grade 1 haze that remained relatively stable at 3 months and by 6 months. At the end of 1 year, nearly 53% had complete resolution of haze. About ART max, at 1 month, the median ART max decreased from 116, which when compared with the baseline value of 174. At 3 months, it further decreased to 101. At 6 months and 12 months, it's progressively increased to median value of 120 and 137 respectively, and all these changes were statistically significant, with a p-value of less than 0.01%. So coming to the baseline densitometry values, when seen in anterior layer, significant changes were seen in subsequent follow-ups. When the baseline densitometry values of central layer was calculated, in every visit, change was seen in every zone except for that 6 to 10 mm zone. When we talk about the posterior layer, when we compare the baseline densitometry values, changes were significant in every follow-up in every zone except in 6 months and 1 year, that too in 6 to 10 mm zone. So the K-mean and K-max reading has similar pattern that peaked at 1 month and post subsequent CXL dip. In contrast to other studies, our studies show a significant change in densitometry values, especially in the anterior layer of cornea that peaked at 1 month. So based on the existing literature, the most common influencing factor listed for the development of haze include pre-op Kmax, pre-op K-mean, and pre-op thinnest corneal thickness and young age of the patient. Also in our study, pre-op ART max had statistically significant association. The strength was, this was the first study that was done in a tertiary eye care system in South India, and we used an objective and reliable method that was pentacam, and our study may help us predict the treatment success and expectation post C3R. The limitation was that follow-up period was just 1 year, so we cannot exclude the possibility of corneal haze that developed afterwards. There was no comparison and control group. Also, densitometry measurement with sign plug camera has its own limitations.
So, nice presentation, but how do you account for like your artmax as well as corneal thickness shows decrease at 1 month and then it gradually increases? What is, I mean, it's difficult to digest how the corneal thickness increases after 1 month or artmax progressively changes. Any reflection on that? Have you compared your corneal thickness on pentacam compared to other methods like ultrasonic or anterior segment OCT?
No, sir, we just use the pentacam.
So, because if you do that, pentacam gives false low tachymetry because of the line of demarcation.
Yes, sir.
That is the main reason for getting a false low. So then all data will become little absurd.
Okay.
And
Okay,
if you
sir.
take ultrasonic or anterior segment, where you actually measure the thing, you will get a much higher corneal thickness.
Okay, sir.
So,
So,
Yeah, that's
very
totally
nice presentation. I just want to know, how did you get the correlation between those things? So, how did you decide that this factor was responsible for this thing?
So using significant like statistical analysis, we came to, we checked that in patients who had a higher pre-op K-mean value, in those patients corneal haze was seen more. The changes in the densitometry values were more significant in keratoconus, I mean the subjects who had higher pre-op K-mean values, sir.
What statistical methods did you use? Sure, you should know about it because
it's
every
really
method has an
Yeah.
issue that how do you decide about the correlation between two findings, right? Next time you should know about statistics because that's very important.
Yeah, definitely, sir. Thank you.
So for me, the main thing, Garima, is that although the title said factors influencing corneal haze,
Yes, ma'am.
but all your results only showed how the densitometry uniformly decreases, meaning the haze reduces with time. And in most of the results, though, I mean, it's possible that I must have missed if you presented it, I never saw a single slide showing that these are the factors and this is how it influences the collagen cross-linking haze, post-CXL haze. And then as Dr. Himanshu asked you about the association, coming up with which statistical method you used to show the association. So in the end, in the discussion you mentioned about the Artmax, but in your results tables I didn't see any other factor or even Artmax being correlated. Maybe I missed it. Did I miss it? So either that, you can change the title because you're not talking about the factors influencing the corneal haze,
Okay.
but you studied the densitometry of corneal haze across time for patients, so that's also fine. But the title, if you're saying factors influencing, then we expect to see that in your presentation.
Okay.
So it's misleading otherwise. Yeah, thank you.
Thank you, ma'am.
So any other presenter has shown up? So then we're finished because we finished the final. So just giving time because it's still 9:45 and these are. Yeah, so the judges have also decided along with me that even if they show up, it's too late now. And with that, we end the session. We thank everyone for all the presentations, excellent presentations, and we hope that everybody learned something. Thank you very much. Thank you to the judges for coming on time and taking charge of the session.